Seeing that girl at the age of 22, after 6 years of being completely clenched, all of a sudden relax, that's an N of one.
One of the important criteria for the case studies that I had submitted to you for our certification program was tracking pain. One of the biggest markers I feel for a successful treatment is how they present the next time they come in and see you.
The nice thing about those kinds of frequencies, both 40 and 89, 40 and 10, the ones where you just don't even have to touch anybody, is you don't have to touch anybody.
I always say the knee has like middle child syndrome.
Calcium ions entering the mitochondria signal the mitochondria to make more ATP. And excess of calcium in the mitochondria kills them.
Thank you for subscribing to the Frequency Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn Pittis.
Hi.
Hello. Hello. What a pretty necklace.
It's labradorite.
Ooh, I like that stone.
I have a labradorite ring that is amazing because it's mostly blue with the iridescence in it.
And what does it do? Tell me about it.
The protective qualities of labradorite are in my file. I have to tell you that I sent Ben Catholi a text about a patient I did this week. That's the high spot of my week that I just can't not tell you about.
Good.
And it got him to say, wow.
Ooh.
You did what?
Ooh.
That was pretty fun. It's not an exact quote.
Great way to start off.
I can
Tease it.
I can look up the, oh no, that his exact quote is, what the heck? That's insane. How cool. And I'll tell you what that is in a second, but first we're going to look up Labrador.
I love that. I love learning about gemstones. And years ago, and I know you've done it since then, you brought a jar of stones that had like inscriptions on them. Do you remember that year? Is that the advanced? Or maybe, yeah, it was the advanced. And
that's right. I gave away hearts for everybody.
Wasn't hearts. These were just oval stones that had
words in them.
Words in them.
Right.
And I chose joy.
Oh, okay.
And then, yeah, the years after you brought the little hearts. And yeah, it's amazing how you can get drawn to them and you don't know why or what they mean. And then I was trying to look up what the different stones meant. So if you find what that beautiful necklace means, I'd love to hear it.
Okay, labradorite is the stone of transformation known for enhancing intuition, which is probably something we should talk about, and spiritual awareness, clear inner vision and communication. It is believed to offer protection against negative energy, which is a good thing, promotes self-discovery, which is sometimes easier than others, and bring hope, making it ideal for spiritual growth, manifesting dreams, and navigating life changes by revealing the truth behind the illusions. The mystical properties are tied to the legends of the Northern Lights being trapped within its iridescent flashes.
Wow.
I got goosebumps. I've never read all that before. I knew it was good stuff, and so
And I think sometimes it's interesting because you and I are science people, but sometimes it's interesting to read about things like this and why we're drawn to certain stones or jewels or whatever. And it reminds me of sometimes when I'm stuck, and as much as I love the buddy, sometimes I just need the laminate and I just need to
Look down the laminate.
look down the laminate and then something just leaps off the page and is choose me, choose me. And sometimes it works. And maybe that's part of that intuition. Who knows what that is?
Intuition part.
Yeah. Or at least sometimes it will help me to ask a question that could maybe lead me to whatever pathology or tissue is jumping up. And so many times someone will say, how did, you know what, that's so funny that you mentioned that. I totally forgot about this whole thing. And sometimes it leads you right to where you need to go next.
Yeah, it's yeah.
Right.
That's
Tell me about your story.
Okay. The story was patient presents with a diagnosis of CRPS. Okay.
Self-diagnosis from somebody.
Everybody,
Okay.
25 years, he has a diagnosis of CRPS.
Okay.
Presents with his pain level at a 7 on medication, having failed with gabapentin, Lyrica, opiates, antidepressants, got himself off all of those. And the only medication that takes him from a 7 to a 6 or a 5, this is 25 years, is everybody just calm down.
You take a deep breath.
It's 140 milligrams of Ambien 4 times a day. Yes, the average go to sleep now dose of Ambien is 10.
Okay, thanks. Because I was doing quick math in my head, making sure that nothing drastically had changed with.
And
okay. So 4 times a day, he's taking 140
milligrams. And it's 120 milligrams. But the thing is that his pain doctor thought it through, and Ambien is a benzodiazepine receptor. Buffalo sauce on chicken wings for lunch before the podcast, probably not the greatest idea. Anyway, Ambien is a benzodiazepine receptor agonist. Your brain makes benzodiazepines. Hence, there are benzodiazepine receptors in your brain. Hence, anyway. And then there's his pain diagram. That's the one sheet that they have to fill out by hand when they get to the office. And his pain diagram is the medial side of his elbow, mid forearm to mid biceps on both sides. The precipitating event was an anterior dislocation when he was 18. 1 surgery, put it back, dislocated again. So they took a cadaver tendon, surgery 2, put it in front. The physical therapist broke that cadaver tendon by doing exercises. The 3rd surgery was, yeah, okay. I'm just going to close my eyes because your face is going to get really icky on this. The 3rd surgeon took his pectoralis major muscle where it attaches at the clavicle and stretched it up so it was over the front, the belly, the tail end was over the front of the capsule. That was surgery number 3. Surgery number 4 was to clean up all the scar tissue in the brachial plexus. And while they were at it, on the same day, they did an ulnar nerve transposition. Yes, that's a good face. And a month or so after that, it generalized to his left arm. A month after that, it generalized to his right arm. Same pattern, not dermatomal.
Right.
6 months after that, it hit both of his legs from mid-calf to mid-thigh on the medial side.
Wow.
He has a diagnosis of CRPS. I did a sensory exam with a little pokey wheel. Every dermatome was normal. I did soft touch and every dermatome normal. I did vibration in every dermatome normal. He said pressure. Excuse me? Yeah, he said, I can't wear socks. Why? Because of the pressure. And then he looked at the table that I wanted him to lay on, and he said, yeah, that's not going to work. He can sit in one particular chair that keeps his hips at 90, his knees at 90, his ankle and foot at 90, and he has to sit up with his spine straight. If he leans back, the pain in his arms and his legs goes to a 7 or an 8. Meds or no meds. Does any of that make sense to you?
No, I'm trying to keep track and notes and make diagrams in my head, and I'm having trouble.
The medial side of both arms,
Yeah.
the medial side of both legs,
Yeah.
mid calf to mid thigh, mid forearm to mid here. It's clearly not dermatomal, so the spinal cord is not involved. Cool. And I said, do me a favor, just supinate, just do this so I can measure the C6. And he said, I can't. Excuse me? Yeah, I can't do that. And this arm, they did the surgery on. That one I could understand, but it was both arms. He couldn't supinate more than 5 degrees, 10
Right.
degrees on both arms. And I went, so clearly it's not spinal because there's no dermatomes that are abnormal. That means it's centralized. So that's 40 and 89. Got that. Can't supinate. I felt the tone in his muscles, hard as a rock. Felt his legs, also hard as a rock. That would normally be 81 and 10, but he's had no trauma, no disc bulges, nothing is dermatomal, so nothing is in the spinal cord. So what increases tone? There was one case at Cleveland Clinic of a 16-year-old girl who had a Pons stroke. When she was 16, she had a hemorrhagic stroke. And I saw her when she was 22, 6 years later, and she's spastic all over. We ran increased secretions in the Pons, and her upper body relaxed. And the PT, Jessie Strecker, was able to range her arms, both arms. Her vocal cords loosened up, her neck loosened up, her chest started to loosen up, and that was the hour. And it's now when you run 81 and 10, if everybody remembers, the muscles soften from the bottom up the front and then from the bottom up the back. So from the bottom up. When we do increased secretions in the Pons, it relaxes from the top down. I don't understand it. It's just a factoid. So I ran 40 and 89 and increased secretions in the Pons because he's spastic in a way that doesn't make any sense. Increased tone, loss of descending inhibition that doesn't happen in the spinal cord, so it has to happen in the brain. Okay? And then the patient, as he's standing up, says, oh, and what about the vagus? What about the vagus? I don't know. I just heard that the vagus is important. And okay. So we had 3 machines, one with 40 and 89, because he's clearly got central pain syndrome. One with 81 and 454, the Pons from neck to feet. And then, what the heck? I didn't want to put another towel on his tummy. So we did 81 and the vagus, increased secretions in the vagus from neck to feet. In 15, 20 minutes, pain level went from a 7 to a 2. At the end of 60 minutes, pain level was between a 0 and a 1. Tone was completely normal. He got up off the table, sat in a chair, sat the way he had sat before. I said, now lean back. that's going to hurt. I said, see. He leaned back and went, wow. And now he's moving his arms and he's talking and he's using his hands and it's like he's spent 25 years. He's finished college. He's an engineer. He's done everything, alternative and medical, and done all the internal work. And I said, well, you've already done the hard stuff. All I had to do was get you out of pain. That's the point at which I texted Catholi, OMG, I did this and this. And he went, that's crazy. So that was my Monday and Tuesday. And on Tuesday, he looked at the table. I said, tell you what, we're going to sit you in the chair. And because he came in, this is the other thing, he came in at a 3. Sit you in the chair, neck to feet, until his pain was a 0. Mm-hmm. Then we got him on the table and he said, I can't, I'm laying on the table. Wow. How? Okay. And then I treated his shoulder, treat the cause. I ran trauma in all those little nerves and muscles, took the scar tissue apart in all the nerves. I love my job.
Okay, here's where Kim says we have a lot to unpack because we have a lot to unpack with this. So there'd be so many, I think, people and so many instances where they would see a pain diagram and then just go after the nerve, right? We think pain, nerve. And in your case, you're just taking it 1 and 2 steps further, sometimes this is how I like to explain it. Sometimes you don't need to get to the exact bullseye, like waft, right? It's not Roger Billica's bullseye, but by deduction, you can eliminate so many other chaotic pathways that you might be tempted to go down. So, like in your case, you deduced it wasn't.
Couldn't possibly be the nerve because there's no nerve that goes from here to there.
Exactly.
And there to there.
And that was a quick, you just eliminated a whole pathway that you could have gone down for days and days because some people just hear pain and they think treat the nerve.
Well, they hear CRPS and they believe it. And it's no, this is not CRPS. I don't know what it is. I still don't know what it is.
Right.
But I know it's not CRPS.
Deduction. Sometimes just knowing what it's not can help get you to what it is, maybe. However, what I'd also like to highlight with this story is some people get really caught up on the label. What is it? How did it happen? And I'm getting more and more comfortable with mileage and age to say, I don't know, it doesn't matter. Who cares? They're like, what? Who cares? It doesn't really change how I'm going to treat or the pathway that we're going to take. And people are like, oh, I didn't realize that. So let's just treat it this way and see what happens. And it's not going to make it worse. And if it makes it better, great. And if it stays the same, we'll change things up a little bit.
And on top of that, there's still a piece of it I don't understand. So when I looked up the PHYS,
okay, yeah,
it's motor, yes. Yeah. And then I looked up, does the PHYS mediate pain?
Yeah.
And much to my surprise, it said yes, through this X pathway. It's like, I have to increase secretions in the PHYS to get rid of the spasticity. Is that going to increase the pain? Didn't increase the pain, so does the PHYS act to reduce pain? So we have to increase secretions in the PHYS to reduce that. I still don't understand, but I knew from experience from that N of 1 case that if you lose the PHYS, you get spastic. So his PHYS didn't work.
Right.
And the PHYS in the medulla are like cheek by jowl. I'm sorry, the PHYS in the midbrain are like they're together. And that created a few extra slides in the 4-day advanced.
Yeah, and that's what the advanced is so great. You just read my mind that yes, it's an N of one. However, like you just have to hear something one time for it to stick in your head and think, if it worked with that person, what if? You're the queen of what if? What would happen if? And to create that hypothesis and to go with it. It's not just throwing stuff out there. There's
Well,
a
and
measure.
there's that thing that says you have to see something 7 times to remember
Yeah.
it,
Yes.
unless whatever it is that you see has an emotional load,
Right.
at which point an N of one, it's in your brain.
Yeah.
So seeing that girl at the age of 22, after 6 years of being completely clenched, all of a sudden relax, that's an N of one that taught me, number one, that the experimental frequency for the pons was correct.
Yeah.
So that number no longer has a little I next to it.
Mhm.
And it also, this is the first time since 2017 that I've used increased secretions in the pons,
Right.
because it's the only thing that made sense.
Right.
There's nothing else that makes every muscle in your body spastic.
Right.
Cord doesn't,
Right.
because there was nothing wrong with the cord, because there was
Right.
no dermatomas. So it had to
Right.
be in the brain. What in the brain manages spasticity? That's the pons. And then the patient said, what about the vagus? Vagus increases brain-derived nerve growth factor, so maybe it can tell the pons to get its act together. And it was so much fun.
I've got that perplexed look on my face. I'm catching myself on our side by side mirror camera, but that is a lot to go through. And you'll see him again on tomorrow.
Tomorrow night, because he leaves to go home, which is cross country.
Yeah.
Tomorrow night, he's taking home a custom care
Yes.
and wraps,
Yes.
because we treat him with alternating current, not
Yeah.
polarized, just because I'm not sure.
Yeah.
We have no imaging of his spine. So alternating, but I don't know if it'll work. So wraps, neck, both feet. And
And
that way he can get himself out of pain.
do you treat him with one machine, or you had 3 machines going?
Yeah. So I have body pain, tight body, pain, tight combo.
Yeah.
And then
And
I alternate 20 minutes of 40 and 89, 20 minutes of 81 and 454, and 10, 20, 40, anyway, and 81 and 109. So I mix them. So it's a 2-hour program.
right.
And we'll see if that works. And he'll find that out Thursday night and then go home on Friday with one machine.
Do you have patients that come to see you, you have great success treating them in the clinic with multiple machines, you give them a custom care to take home, and they don't feel like the custom care is working ever? Or
Oh,
they had bigger results with you?
probably. The challenge is where you have a 40 and 10 patient that
Right.
also has increased tone.
Yeah.
So I always do body pain, tight legs as separate, and then pain and tight combo.
Right.
And the default current level for the custom care is 100 microamps, and I'll go in and change it to 150. So
Mhm.
that's another possibility, is it just happens faster with a higher current level.
Yeah.
The nice thing about those kinds of frequencies, both 40 and 89, 40 and 10, the ones where you just don't even have to touch anybody,
Yeah.
is you don't have to touch anybody. We know it's not placebo. There's not anything I'm doing to them. I am not doing any sort of hands-on, you're going to get better hypnosis magic stuff.
Mhm.
It's just, and They all go home with concussion in Vegas. And I have a traumatic brain injury patient this week too. And he's got a vestibular injury that's mild. And he wants to know, this is what my deficits are. Little parietal lobe, little temporal lobe stuff. And I said, the most important thing for you to do is run concussion in Vegas and the long version of vagal tone every night. And then we'll do brain support.
Right.
And then I'll add the frequencies for the temporal lobe because it's still got an I after it, but I have an N of 1 where it worked, I think. So I'll add that. And then we'll see. And then the other functional neurologist chiropractor that he saw did his woo thing. And the patient said, are there any supplements I should take? And the guy said, no. And I went, yes. Mitochondria, huperzine A, and the vagus. Brain-derived nerve growth factor, deuce glutamate, brain-derived nerve growth factor. That's what the vagus does. That's the fact that we now have data showing that the vagal tone protocol works is very reassuring.
Yes. So one of the things as I'm putting together their rehab course is I'm pulling up my case studies that I did 10 years ago. And there's just so many mistakes that I made. But anyways, you do the best that you can with what you have. But one of the important criteria for the case studies that I had submitted to you for our certification program was tracking pain, very good charting before treatment, after treatment. And one of the biggest markers I feel for a successful treatment is how they present the next time they come in and see you, whether that's the next day or the next week. I want to make sure that if they left the clinic at a 3, they're coming in at a 3. I'll take a 4, sometimes a 5, if depending on what's happening, but I don't want them ever to come back with the 7 or 8 that they said they were when they initially saw me.
Yeah.
So I think that's blown past that, but I think that's a really important piece to highlight is when they come back to see you, the pain stayed down.
Yeah, that's true. It's been really fun getting to redo the advanced slides. There are now 4 slides on calcium molecules. So we have the hardening 91, we have calcium oxalate 217, we have 766, 276, and 242 for hardening minerals.
Yeah.
And then in the advanced, there are 3 frequencies for calcium ions. Then you start looking at what do calcium ions do in the brain, the heart, the skeletal muscle.
Right.
And then I saw a post on Facebook where somebody said, there is somebody who said that post-exercise malaise is an excess of calcium in the mitochondria. So we should take calcium out of the mitochondria, and that will fix post-exercise malaise. And a bunch of people agreed with him. And I went, wait, try looking it up. Post-exercise malaise lasts 3 to 4 days. Right, that's how it works. Calcium ions entering the mitochondria signal the mitochondria to make more ATP. An excess of calcium in the mitochondria kills them. If post-exercise malaise was caused by an excess of calcium in the mitochondria it would not be finished in 4 days. The patient would be permanently trashed. I think that's the technical medical term.
It is.
Permanently fatigued. For whoever said that it's an excess of calcium in the mitochondria was not thinking
Right.
about how it actually works.
Right.
So if you take calcium out of the mitochondria, the thing that you have to consider is, what if this works?
Right.
So what if the level of calcium in the mitochondria is correct and post-exertional malaise is not caused? What if that guy on the internet was wrong? What if it's not caused? It can't be caused by an excess of calcium in the mitochondria.
Right.
Okay, can't be, because then the mitochondria would die. Then if it works, so we have to start with the question, what if it works?
Yeah.
If it works, what are you going to do? If you're going to make it worse.
Yeah.
Oh, okay then. So maybe rethink post-exertional malaise. Where's it come from? Look up a different guy.
Yeah.
And it's maybe more difficult or easy. I don't know which one it is, but maybe if you have, I guess it's critical thinking. I guess if you are willing to start at the beginning, work through the logic, look up different sources. These days it's pretty easy. Google it.
Yeah.
It's okay. Really? The PHYS does that? It participates in pain? Who knew? Calcium in the mitochondria. Did you know the mitochondria has an ACE2 receptor? Hi, puppy. Oh, she's getting gray in her muzzle, white in her muzzle. Oh,
The other one is barking, so I'm trying to mute myself.
okay. Anyway, I guess think it through is also another slide. Think it through.
I think you've been great at thinking it through, or at least showing us how to think about, what tissue it could be, the pathology, the story. How did we get here? To me, that's the question for the sports and rehab course is, how did we get here? Yes, it's scarred. Yes, it's inflamed. How did we get here? Nothing comes from outer space. But to go to get there to like that middle part of the hypothesis, and like you said, to follow it through to what happens if we do increase secretions to X, Y, and Z, what could happen? We talk a lot about with the bone marrow because we have a lot of frequencies. Bone marrow could be affected by a lot of things. The only time I use bone marrow is thanks to Ben Catholi using 14. So edema and bone marrow. And that is only for things like traumatic shoulder, where we see on an MRI that there is bone marrow edema, and I only run it for a short period of time. And it seems to be the only thing that helps the pain when there is that type of trauma there.
The only other time I run it is after a hip replacement.
Yeah.
Because after my left hip replacement, Kate Adams was working on my TFL and it would not relax. And all of a sudden she ran something and the TFL just turned to pudding. I said, "What are you running?" She said, "Scarring in the bone marrow." Excuse me? Scarring in the bone marrow. Okay. When you look at what the TFL does with rotation of the femur, and if you stick a titanium pin down into the bone marrow, in the process of healing, it's going to scar. And then the TFL, among other muscles, has to be tight to keep it from hurting the bone and the bone marrow. Okay, that makes sense. So that's the only other thing I ran, and I used that last week.
No, but like you said, it's thinking it through, it's thinking through pathology, it's thinking through cellular activity. It's thinking about biomechanics. If this rotates this way, why would it cause pain this way? And it's just, again, it's helping to tell the story that helps you figure out where to start at the very least. And you and I both see pretty complex. It's not the I just sprained my ankle 2 weeks ago
Yeah.
kind of situation. So asking the questions, getting the story are just really integral parts. Using the pain diagram, the visual sometimes can help you more than anything. So as you were talking about medial, you're starting to think about things bilateral medial, wait, bilateral leg, wait, what, not the cord. And normally when you start thinking about if something's bilateral, I jump to the cord right away. Nobody has bilateral plantar fasciitis but you just have to, at the very least, my phone was going off. Use the critical thinking skills that you have.
And there's one other thing that you said a few minutes ago where you look back over your chart notes from 10 years ago and the mistakes you made. And I actually just put a slide in the advance. It's the only difference between the master and the student is the master has made more mistakes than the student has.
Right.
And I think I learned more from guesses that aren't correct.
Yeah.
The thing that I learned, or that it took me 5 years, I think we added it up, 5 years and 30,000 patient visits, not patients, but patient visits, was to understand and believe that the frequencies always do what they're described as doing. So if it didn't work, it's that that frequency and that model for what is causing the problem or causing the symptom, that model was not correct, because treating it as if that model was correct
Right.
didn't work.
Right.
So sometimes, yes, it is scarring in the nerve, but that's not the first thing you have to treat.
Right.
So I still have to take his ulnar nerve transposition scar tissue apart, but
Right.
that wasn't what the problem was.
Right.
Don't you just love being us?
I do. I love listening to your stories so much. I'm so grateful for these Wednesdays. So it's like my own private study hall. I think we had a question though. I don't want.
They're there. Hi, guys.
Okay. How can frequency specific microcurrent be integrated into the treatment plan for a 2-year-old with hydrocephalus?
Whoa.
Specifically, can FSM protocols help address post-shunt balance issues, support developmental milestones, and speech motor skills?
Okay. I don't know what Grantley's clinical degree is. Back when, oops, where'd you go?
Oh, sorry, I clicked.
There it is. When I was in college, I worked at Easter Seal Summer Camp, and we had 2 or 3 over the 2 years, 2 summers I worked there, that had really significant hydrocephalus that was not well controlled with a shunt. So for those of you that haven't ever seen it, hydrocephalus is where, and Eduardo's going to talk about it, I'm going to talk about it. Spinal fluid is created in the ventricles and it flows around the brain and it goes down the dura on the spinal cord and then it goes up, and there's a flow pattern to it. Somehow in hydrocephalus, there's either fibrosis at the outflow. They don't ever try and fix that. The solution for hydrocephalus is to put in a shunt, basically at the foramen magnum, I think. It goes down the neck and drains into the abdomen where it's reabsorbed. And that just keeps the pressure normal. It depends on how quickly they find the hydrocephalus. So that's why the pediatrician measures your baby's head when it's born, and then it measures it at each milestone. And if it gets too big, they go and do imaging to find out if they have hydrocephalus. So the post-shunt balance is if the shunt drains too much, they get terrible headaches. It's like having a spinal puncture when they do an epidural leak and you don't have enough CSF cushioning the skull. Your brain settles down and you get horrible headaches. Okay, and I think that's what you mean by post-shunt balance. If the shunt gets clogged up, which is really common, having to replace the shunt every 6 months, a year, 2 years is common. And so there's the shunt and balance issues. Then there's when there's too much fluid. So there's usually about 1.5 to 2 millimeters. It gets up to 3 to 4 to 5 millimeters of the skull expands. So hydrocephalus kids have big skulls. Think about what that compression does to the blood supply, to the axons, to the brain parts. So they usually have the kids that I worked with drooled a lot. That means the vagus is getting jacked up somehow because wet, runny saliva is vagal, anyway. So there's that. They have trouble with speech, which means that the speech centers in the brain are compromised. Those are in this part. They have trouble with language. All of the developmental processes are delayed or not working right. That's a really good question, and it's complicated. So speech and motor skills like walking, where do you go? If you think about what gets compressed, you're talking about the sensory motor cortex. That's a good place to start.
Right.
Trauma, hypoxia, necrosis, increased secretions in the vagus, BDNF. Then motor, I guess the pons, are they floppy or are they tight? Most of the ones that I've seen are tight. So maybe now after this week, my N of 2 might look after trauma, paralysis, increased secretions of vitality in the pons. Then what? So follow the spark. Where does the problem start? They have trouble with speech. That's one part of the brain. Which parts of speech do they have trouble with? Is it turning, I know the word, but making it into the motor part of how you say the word? That's a really complicated question, Grantley. Thank you.
Yeah.
This is why we spend probably 3 hours on the central nervous system.
Right.
And the 4-day advanced.
Right.
I would actually start, if you can catch them before the shunt, scarring in the dura, and the arachnoid has as its job to absorb spinal fluid and circulate it. So what if the arachnoid gets scarred? The PIA is fibrous, cushiony, and I know all this because I just redid that whole section of the advanced. I had so much fun that week. And then the dura is tough. They're both protective. The arachnoid has fingers that absorb spinal fluid and help to recirculate it.
Right.
So like for Tarlov cysts, you look at where they are, how they work. It's the arachnoid, it's the capillaries, it's the dura, it's the nerve. That's a Tarlov cyst. It's a place where the spinal fluid is not absorbed. Why? Same thing with the syrinx. Spinal fluid goes, I can't remember if it goes up or down, the central hole in the spinal cord. But a syrinx is where that hole expands.
Right.
Is that because of scar tissue above or below? Or I just have this trouble with, I don't know. Okay, make something up. Make a guess. Create a hypothesis.
Yeah.
Can you make it any worse? Probably not, because syrinxes get worse.
Yeah.
Left to their own devices, a syrinx will get worse. Maybe not tomorrow, but in the next year, it's going to get bigger. Okay. So can you make it worse? Probably not.
Yeah.
So what do you treat? What's that hole made of? I don't know. Connective tissue? Spinal cord? Maybe.
And you don't have to knock it out of the park the first stab at it. So like you said, I don't know, we'll start somewhere. Connective tissue, connective tissue and fascia are great starting points because they're everywhere. Will it knock it out of the park? Probably not, but let's start someplace, and that's a great place to start.
Friend who we thought might have a deep vein thrombus, like the length of the posterior tibial vein. Eek. I met her in the emergency room, and she was sitting in the hallway waiting for imaging to come get her. And they let me come back and watch her ultrasound.
Yeah.
You should see the fascia compartments you can see on a diagnostic ultrasound. And then you see the arteries and the veins and the bone and the fascial compartments in the lower leg.
Yeah. Amazing. Beautiful.
And then take a breath in.
Isn't it amazing?
It's so cool.
And were they okay? Did they have a DVT?
As it turns out, the manual, remember Hohmann's sign where you squish it and it goes ow, and you feel in between the compartments and where that vein should be, there's this lumpy thing instead. Those were all strongly, excessively positive.
Yeah.
And nope, no DVT.
Wow.
She had 6 hours of lower leg cramps.
Right.
Which could either have caused a DVT or been caused by a DVT that was forming. As it turns out, there's no DVT. Okay, now we know. You rule out the worst first. And then now it's a matter of you really need to eat more Kalamata olives and get your sodium and potassium up.
Right.
Let's try that.
I love a prescription that gives me olives. Like the DVT, I tell the story all the time. I've been practicing over 25 years. I've seen one once in the clinic that was the textbook person, was a runner, but had come off of a flight. It looked angry and hot, but had a very important race in 2 days. And Kim, I beg you, please, you have to work on my calf. I said, no. Not until you go get this checked out. And I will hold the appointment and I will stay late because this is when I was practicing in Canada and trips to urgent care could be very long wait times. And I was right. We did have one. And it was one of those, I hate it when I'm right, but that's why Hohmann signs, and there's so many criteria that you could look for. And I know we have a case study about treating one, but
which is going to get published, by the way. It's a poster right now.
Yeah.
But it has been submitted, and I think it's the APTA journal into a physical therapy, mainline physical therapy journal. And they sent it back to her for a few edits, but it's looking as if Jesse Turney's case report is going to be accepted for publication, which puts it's an N of 1, but it's an N of 1 that is impossible.
Yeah.
And that's what that is going to be talking about, which is N of 1 statistics.
Right.
Pre and post, pre and post, pre and post, front and back. I don't know what he talks about. All I know is that Tad talks about stuff that should be Greek, sounds like English, but not really. And somehow at the end of minutes, he makes it completely understandable. So I'm pretty excited about that.
That is amazing. We have so many instructors that I think really have a gift for explaining very complex subjects. And then you walk out of that room, not just like memorizing it, but like truly understanding it and feeling competent in talking about it. And that's a gift. Like, we're very lucky to have such amazing speakers.
I had so much fun today. This morning, I went to the trophy shop and ordered awards for the speakers. And it's, no, we did that one, we did that one, we did that one, and that one, and I need a new catalog. So we have a new presenter award. I have 6 surprises for faculty.
Wow.
Yes, there's a saying that I take to heart, which is I support those who support us. And for me, it's really important to acknowledge the gift that the faculty at the advanced, and I call them faculty, not speakers, because they are teachers, the gift that they give us in their area of expertise. And it's a long day,
Yeah.
and they, each of them focuses, laser focused in their area of expertise. Somehow, Eduardo has combined the Dura and the Vegas. That's good face. It's, what does the Dura and the Vegas have to get? Okay, I'm not eating eggs for breakfast at all in the advanced.
Thank
No
you.
food poisoning for me.
Thank you.
Thank you, Heather, but we're going to just do that. And because I want to hear this. So what do you mean the Dura and the Vegas? How's that work?
I want to know.
Yeah. And then Patrick Wood, midbrain, and the dopamine pathways.
Yeah.
What dopamine pathways? Where does
Yeah.
dopamine go?
Great.
And then, did you know that the precursor to dopamine is glutamate? And I think of glutamate as being the bad guy in the brain, but
Yeah.
dopamine starts with glutamate. How's that work? So we'll find out. And then there's, are you still doing the knee? Do I have your title right? Okay.
Yeah.
Okay.
And thank you for, I don't even know how we came up with it, but we were texting back and forth, and then I was like, that's it. I'm going to do it. I'm going to do the knee. And the knee seems like this easy joint, but it's really not. It's got a lot going on, and there's a lot that you can miss. And so I'm so excited about, because last time I did the hip, and that was a great talk. And as I'm redoing this presentation, there's a lot that the knee, like I said, that there's a lot that we miss. And so I think that's going to be an important feature of my knee talk, is what you didn't know.
Well, and there's no way to look at the knee in isolation.
Right.
If you're looking at the knee, you have to look at the arch of the foot, the ankle, the talus, and the hip.
Yep.
And 81 and 10, and now 81 and 454.
Right.
Who knew?
I always say the knee has like middle child syndrome.
Exactly.
Because it really is stuck in the middle between these two other pretty great joints.
We could have buttons made. The knee has middle child syndrome.
We could. We had that whole Star Wars buttons a couple years ago. We could have knee stuff. But yeah, the advanced, whether you're coming in person or you're joining us online, it's such a special continuing education / networking experience that.
Oh, and there's Kevin looked up the numbers. I thought we were at more, but Kevin says we have 208. Some of them are online, some of them are in person.
Yeah.
I don't mean to keep reminding people of this, but I'm 79. I'm going to be 80 in September. This is the first, and we hope not the only 4-day advanced, because we'll go advanced symposium and then 4-day advanced. Thank you. I think it was Elvira that asked, whoever asked for a 4-day advanced, because like for the acupuncturists, there are 5 slides on when to use the frequencies for balancing the acupuncture meridian in the hip, the shoulder, etc. So there's all sorts of new stuff in there that I didn't even know I didn't have in there.
You don't know what you didn't know until you don't know it.
And until somebody gives me an extra 2 days.
Right. And yeah, this is going to be exciting just by definition of how much extra time we get to have with you and going through everything. And
I know the sale is over, but you can still sign up. It's worth it.
Yes.
And it's deductible.
Yes.
It's a professional development expense.
Exactly. And you can deduct hanging out in Arizona in March, which is in itself is just a treat. And the food and all the things. So come join us. And I have a bigger room. I still have space for a couple more. So
Do you really?
yeah, a couple more.
Oh, that's exciting. Yes.
Because I still want to keep the quality of the class true to what I'm used to, and that is a smaller group.
Do you have assistants?
I do.
Oh, good.
But I still want to be able to oversee and make sure everybody feels good about what they're doing.
Yeah.
Yeah.
Oh,
It's 4 o'clock, so
I
we're gonna
know.
have to unpack all my other stuff next week, but
Okay, next week's your turn.
we'll figure it out. We always do. Okay, that's it.
Okay.
So we'll see everybody next week and do good things.
Do good things. Have a good week. Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.